is the number one pillar for sustainability, human sustainability. And very rarely do men talk about the illnesses or the things they're dealing with. And I thought it was very important that as we have marked International Men's Day, that we actually pick a subject matter that's relevant to men, but guess what? Relevant to women as well. As women, we have partners, husbands, sons, fathers, and very often we're not having a necessary and important discussion with them. So I am glad to welcome my friend, Kingsley, Professor Kingsley, although I call you Prof most of the time, or Kingsley. Thank you for coming. So I have to start by asking you, what are some of the symptoms? Because I don't think many people talk or know the symptoms of prostate cancer.
Hello. First of all, Doctor, I have to say that it's a huge honor for me to be here today. I couldn't miss it for anything in the world. So, to answer your question about prostate cancer, the first thing I want everybody to know here, when the people talk about symptom and symptom and symptom, you don't want to have symptom of prostate. If you have symptom of prostate, then it's probably too late. Okay, so you want to get prostate cancer, catch it early when you are asymptomatic. That means you don't have symptoms. Don't wait until you're waking up 15 times at night to pass urine, or you have pain, or your urine has ceased. Then it's probably too late. So I would encourage men, if you have a family history of prostate cancer, your father, I know in Nigeria, from all the information that I've got since I've been involved in coming to Nigeria to perform this type of operations, that a lot of people don't know what killed their father, but they know their father died young. And the parents of those, that generation, they never talked about these things. They were not open. They hid it. Even your mom will hide this from you, that your father is suffering, and that's a problem. And you might be in school, and then you get a call one day that he's dead. So a lot of men died of prostate cancer those days. If you have a family history, your father, your uncle, your brother, first degree relatives, then it becomes extremely important for you. You must get yourself checked, and I would recommend, as a black man, you must start to check if you have a family history from the age of 45. You have to do a simple blood test called the PSA, which stands for prostate-specific antigen. It's only released by the prostate, so it's a good biomarker for something happening in the prostate. Not necessarily cancer. It could be simple enlargement or infection. But if that marker is raised, then it means that we have to look at you in more detail. So you need to do that if you have a family history of prostate cancer. Everybody sitting here, apart from one or two people, we're all black. Being black, unfortunately, is a risk factor for prostate cancer. It's sad news. Because if you're black, not only is the incidence of prostate cancer higher, you're likely to be more aggressive and you're likely to die from it. So, with those three bad red flags, if you're black, you should consider checking your PSA from the age of 50. I push it to 55. Just so that I can make people not to panic. But, you should really consider that.
I hope everyone is listening carefully. 45. I'm not even going to do the 55. 45. Start getting yourself tested. encourage your children, your husbands, your fathers to get tested? Because this is avoidable, is what I'm hearing from you. It is avoidable.
Well, I mean, if you got it, in UK, they say you got what you've got. You can't hide from what you've got. You've got it. If you've got it, you've got it. You just have to deal with it. So, the importance of finding it early is that it can be cured. You just watched robotic surgery. It's just one of the many options that you can have to cure prostate cancer. It's curable, and if you find it early, it's so good because not only can we cure the cancer, you can have all your functions back. Your erection, everything can be given back to you. But if you come late, when the cancer has grown, it's eaten into the nerves, it's invaded the surrounding structures, then I'm afraid it's a dogfight. It's a dogfight, and one bad thing about prostate cancer or problems is that I give you one statistic. Is an old research paper that was published by Robon, one of the American colleagues that we know very well. So this is an economic analysis of prostate cancer. If you find prostate cancer in the US, for example, and you find it early, you treat it, it costs you $10,000 on average. Yeah? Okay. If you find it late, when it's spread, to just keep you alive to see the next year, you're talking about $33,000. It might sound small to billionaires around, but we're talking about 300% cost. But the worst aspect of this is that you're not even going to live. You're going to die. It's just to keep you alive to see the next year. And you're spending 3 times the amount of money you would have spent to cure it. So here I see men, people have come to me, they have 20 buildings. They tell me, Prof, I'll give you one building. A gentleman offered me 1 building if I can save him. And I told him, keep your building for your children and grandchildren. It's not, you won't make it. It's spread everywhere. His spinal cord is already cut because prostate cancer spreads to the bone. When it goes to your spinal cord, it will cut it into half, and so you become crippled. And there is nothing that can be done. Okay, so it's very important. It's so expensive to control prostate cancer when it spreads. And if you're in UK or America, you live 5 years. And that is because, we can give you those drugs. They're available. They're incredibly expensive. You're talking about probably spending £5,000 to £7,000 every month on pills to keep you alive to last 5 years. In Nigeria, you'll be dead in a year and a half.
Well, that's an eye-opener. Nothing more sobering but the reality of what it is. And yet men don't talk about this, and there's very little said about it, except you're a pioneer and you're an advocate for it. So here's my question for you, because I know robotics is your angle. Why robotics as opposed to the more traditional?
Okay, that's an excellent question, Doctor. Right. So, open surgery is dead. I'm trying to find a good way to say it so that I don't upset a lot of people. And I understand it because you've gone to school, you've trained to be a surgeon. In Nigeria, they teach you how to cut people open and perform all sorts of surgeries. When I was growing up, I remember being taken to the hospital to visit my dad's friend who had appendectomy. And it was a big deal because, he wasn't allowed to eat for 1 week. Yeah? And all sorts of people visiting him. He was in hospital for 2 weeks. Yeah? If I remove your appendix at 8 o'clock in the morning, you will be eating at 8:30, and you will be here, sitting here, talking to us. And nobody will know you had an operation. That's where we are. This is 2025, going to 2026. I'm afraid I was invited to come to Sokoto to talk to the whole Nigerian postgraduate doctors, the whole who is who in doctor in Nigeria, fellowship, everything. I accepted to go to Sokoto. I've never been to the north in my life. That was my first time. So I went to Sokoto to give them a talk. And I told them that I'm sorry, but all of you need to go for training. You can't stop what is going to happen. You can only be left behind. You can't keep cutting people open. It's done and dusted. We don't even teach it in UK anymore. And I'm talking about good 20 years. We don't teach open surgery, prostate, anymore. Nobody. Yeah? So, with the robot, I'm looking at you, and I'm seeing you with my naked eyes. Imagine a system where I look under the console you just seen on the video, and I see 10 times magnification. 10 times. It's like you are looking through a microscope. And when you see the tissues, you see every nerve, if you see a hair, if I cut your hair and I look at it with the robot, it will be so big, like you got a stick. That's what I'm talking about. And then you can dissect. You don't destroy any tissue that doesn't need to be destroyed. You remove the prostate and leave the man with his erection, with his urine control. Why men don't talk, doctor, is because patients tell me they have a friend that went to Port Harcourt, had operation, died. This one died. The mortality of prostate surgery before I arrived to Nigeria is more than 50%. Do you know what that means? It's toss of coin. So if I throw a coin up, head or tail, it's locked. And I've been operating in UK for a long time, and I've not had one death. And I've not had anybody. People come and go. Yesterday I operated, and I'm here. And the gentleman got home before me. Before I could get to Lagos, he got home. So robot is here to stay. We talked about passion with the other guests. I'm not done until I get robot to the doorstep of every Nigerian. Whether you are in the north, you are in the east, you are here, we'll get robot to you. You will have the operation that you deserve. And when we are finished, the history will write it that people are surviving. You go to operation like you're going to have a pancake in a restaurant with your friends, and then you go back home the same way you came back, and nobody will even know you had an operation. That's the vision.
That's the legacy. That's the legacy you want to leave behind. Yeah. That you would change the face of operations in Nigeria by making it more robotic.
Yes.
Less invasive.
Yes.
Quick recovery.
Quick recovery. Everything is automated. If you come to the TPC, it's automated. You go and pee in a special machine, we watch it on the computer, on the phones. Everything is automated. You don't have Gone are those days, and you have to leverage technology, and technology is here. And we know when the governor came, he was shocked. He couldn't believe it. He couldn't believe. You walk into the place, and he saw things that he didn't know was possible. But it's possible now.
It is possible.
Yes, it's here.
Yes, it is. Well done. I'm going to turn to the audience very quickly because we want to be interactive. Gentlemen, ladies, any questions? Oh, I've got a hand up there.
I just wanted to know how much does it cost in Naira here?
Yeah.
And it would seem to me that obviously it's only if you're rich that you can afford such an operation.
Okay. So that's a very important question. I get asked that all the time. In fact, I did a round in the newsrooms and they wanted to know the cost. But I give you a context. Actually, if you look at prostate in blood category, I know the cancer, the C word, is the one that terrifies everyone. Okay? But I can actually tell you that prostate cancer is the less common pathology of prostate. If you look at 100 men, the incidence of prostate cancer will be 20-25%. The vast majority of prostate issues are non-cancerous. And then, so when I came here, one of the things that we had to do is to educate and to get people to come, because then you can be told the truth. You don't have cancer, you don't have cancer. Don't go to some hospital where they say operation. They do unnecessary surgery for you and cripple you without having any problem. Before I came here, I had to see a gentleman who came to see me from Jos. It's one of the reasons why I had to make it. I gave him a 10:30 appointment because he had to go back to Jos today. And they already wanted to operate on him in Jos before he found me and spoke to me. And I talked to him on video. And he come here today and run tests, and he doesn't need anything. Absolutely nothing needed. And he's going back. Okay? So such cases give me more joy than the actual robotic operation or all these complicated things that we're talking about for our country. Yeah? So it's about the less talked about issues more than the ones we're talking about. So let's go to the cost of that. If you, unfortunately, as it is now, I will consider it a little bit more expensive in the Nigerian context, and I put Nigerian context in quotes. Very important, because to get the robot, I planned it for 10 years to bring robot to Nigeria. The company won't allow the system to come to Nigeria. Before Nigeria, it was in South Africa. And even in South Africa, they had problems. There is always a problem with Africa. When technologies, companies in US want to do this, and they get disappointed. So even in South Africa, there is a problem. So it seems like Nigeria is the only place where there is a functioning Da Vinci system. Okay? So I planned it for 10 years. They said no until I found a way to make them say yes, and I brought the system here. Incredibly expensive. Even at that, when the system arrived, they seized it, the custom people. They don't even know what it is, but they opened it, and then it was another battle to bring it out. Now you bring it out, every time instruments that they don't even know about is shaped. This is medical, Instead of saying this is your tax pay, it's locked up months and months. Yeah? But I've got access to government now because I'm talking to government. And I'm telling them, you waive all those fees and you do that, then I'll tell you how many Nigerians I will operate for free every month. I will operate on Nigerians for free if you waive those things. Why do we have to pay the money to people I don't see? Yeah? They should waive it. So the cost of robot is 30% the cost of robotic treatment in UK. So in my center, it's £25,000 to do robotic surgery. And only it can know the people. I've been operating on Nigerians before I started coming to Nigeria. In fact, the first operation I did in Lagos, I moved the whole equipment to operate on one man in Lagos because the pandemic struck before I could do his operation and they couldn't travel. And the British citizens could travel. So he asked me to come and operate on it in Lagos. And I did that operation and nobody knew about it. So, and that was going back, I started thinking, I felt so guilty because I thought, okay, I'll come to do this. How about the people who can't afford to do this kind of thing for me to come and do it? So I thought I had to change it. And then it took 2 years before I was able to plan it and then start coming to do it for ordinary Nigerians. So 30% of the cost in UK is so cheap. And we've been able to achieve that by not paying VAT because in UK it's 20%. That 20% cost goes to the patient here in Nigeria. So we bypass the VAT because when the equipment gets shipped out, we claim the VAT back. Okay, so we give the cost to Nigerians. And I was able to also leverage on the fact that it's a third world country, I'm operating on less privileged people, and they gave me a lot of percentage off, which I transmitted to Nigerians to be able to get it to 30%. But even at that, we're still working on it. We're going to expand robot to the north, to the east, so that people can get it at the doorstep and it will be cheaper. I'm hoping that I can get it down to even 50% from what it is. Because at the end of the day, for me, it's not about, I know we're talking about scaling up business. I'm not a businessman. I've never been trained to be a businessman. I'm only a surgeon. I'm a surgeon that I'm one of the lucky ones. Lucky in the sense that I've been opportuned to be able to use my talent. I worked hard and focused, and I was able to achieve things and got paid for what I achieved. And I put all that money to my country to help with people.
There was another hand. Actually, there were two hands. One there and one over here. Please, don't know where the mics are. You have it. Sure.
Okay.
Go ahead.
Firstly, I just want to say you're incredible, Professor Kingsley. Absolutely incredible, and it's a privilege to be in your presence today. So well done, and I pray that God will continue to bless you as you bless our country.
Thank you.
Now, my question. You've mentioned about routine checks to prevent having, prostate cancer and early detection. I just wonder, because there's a lot of stuff I've seen on social media that suggests that there are also other lifestyle changes you could implement to prevent it. For example, the one I've seen more commonly, and I just wonder if you could perhaps bust this or state if it's true or not, that for men, the more often you have sex, right, you reduce the risk. Is this true? And if not, are there other lifestyle changes to prevent it from even happening in the first place? Thanks.
So it does not work. There was one study decades ago that I mentioned something like that, but it's not been proven and it's not true. So, frequency of sexual intercourse has no preventive effect for prostate cancer. So many prostate cancer preventive trials have been done. Tablets have been tried, and there is an important tablet. These are in the class of tablet called the 5-alpha reductase inhibitors. So these are like finasteride, dutasteride. They were studied, and unfortunately, they failed because of the mechanism. In fact, what that study showed, you terrified everybody, is that if you're on those tablets, you're more likely to have high-grade cancer. Yeah? So if you're a man on finasteride or dutasteride, your doctor should have counseled you based on this study. But I know that Nigerian urologists don't even know this study. Yeah? So I don't give finasteride, dutasteride to young men. I give it to a man who is 70 years old because I know that if you have high-grade cancer, you already lived your life. But don't give it to a 50-year-old because there are quickly, because the drug companies quickly wanted something to rebuff these findings. The finding is true, but now we have what we call ad hoc analysis, which analyzes the analysis. And we think that is because the drugs shrink the prostate and makes cancer easy to find. And that's how we could explain why you're finding higher risk tumors in men who are on that drugs. So drug therapy to prevent prostate cancer does not work. There is no drug. Diet is another one, because there is many patients have come to see me, but there's one that I remember. I'm trying to personalize this thing so that it makes sense. And this man had PSA that was high. He was advised to go on diet. He was asked to take soursop and tomatoes. So he made his wife boil tomato every day and bottle it for him. He was drinking tomato and soursop. Yeah, if you go to a market now, soursop is very expensive in Nigeria because men buy it, crush it, drink it. Doesn't work. This man came to me, but his cancer already spread everywhere. And he told me this story, that's what he's been drinking for 3 years, judiciously every morning. So what is contained in tomato is lycopene. Lycopene is what is studied. And the reason for that study is actually because there is a low incidence of prostate cancer in Mediterraneans. So if you go to Greece, all that Mediterranean belt, Lebanon, those places, they all have low incidence. So scientists started thinking, why do they have this in their diet? Because you go there in Greece, you will eat their olive oil, all those vegetable things you eat when you go on holiday. So that's what led to studying those Mediterranean diets as a potential preventive dietary recommendation for prostate cancer. Unfortunately, all the research, a lot of billions pumped into this research, they all failed. So there is no scientific basis for dietary control. However, you don't get big. Yeah, I say big, high BMI. We like to not make people feel guilty. So we don't have to say any F word or something that will make you feel uncomfortable. But don't get big, because there is confirmed. If you have a belly waist, if you take a tape along your belly button, that level, throw it around your waist. If it's over 104 centimeters, you are more likely, if you have prostate cancer, to be aggressive and you're going to die from it. That is a confirmation. We know that. Why? We don't know. But we know now that if you look at on the genetic, I didn't do lab genetic research. It didn't interest me when we were doing research. My friends is a professor. He'll be in Nigeria soon to do 1 or 2 surgeries here. He went into lab research, but I prefer the translational research, so I went into translational medicine. And that's where I did my research, even at the University of Liverpool. But we now know that insulin growth factors have a serious role to play in prostate cancer genesis. Yeah, insulin growth factor. So when you talk about IGF, you talk about, so that will explain somebody that is big. Yeah, yes. So you can now see where the trajectory is going, and that also prompted research in metformin. Metformin that controls that pathway. Can it prevent prostate cancer? Since we know insulin growth factor. So metformin that diabetic people use has also been studied, and unfortunately, it does not work. Yeah. So we're also part of trials that we're doing. There are so many of them. Research. I don't want to bore you. We're gonna get late here, but just be healthy. Don't go too big. Yeah, because if you're big, your PSA might be low, but you have aggressive prostate cancer. Yeah? If you're diagnosed with prostate cancer with a low PSA, it's more aggressive. I don't know if I'm making sense. That's why that PSA blood test that is normal does not exclude you from having prostate cancer. Okay? If you have prostate cancer with a normal PSA, it's bad news. Because your cancer is so aggressive that the cells of the prostate don't even resemble normal. So they don't make PSA. And that is why doctors in Nigeria, they are wrong when they do PSA and it's normal in a guy who may have symptoms, and they dismiss him and say everything, your blood test is normal. No, we know that the more aggressive, the less PSA event. So you need to see somebody that knows what they are doing to be able to sort you out. Yes.
Hi, Professor. Thank you for all your insights and everything that you've done for us in Nigeria. I want to ask, I have a close relative who has just done an MRI to check for prostate cancer. The PSA was a bit high, which was why the hospital ordered an MRI. Is this conclusive? The MRI, they said it was okay. Is it conclusive? Or is it possible to have an okay MRI and still have prostate cancer?
Fantastic question. Fantastic. Yes, I started preaching about pre-biopsy MRI in Nigeria. First of all, I have to commend the hospital. They have listened. They now do MRI scan rather than subjecting a man to unnecessary biopsy, which is invasive. Yeah, we have tools now. MRI scan is a functional MRI. Okay, now we did, and one of the pioneers of the research on MRI scan and functionality that we did in UK, and I'm glad now that it's mainstream in the diagnostic algorithm of prostate cancer. So that's good. But MRI scan has deficiencies. And that's what I'm trying to also preach to them. MRI scan has 20 to 30% false negative rates. So, the MRI scan of your relative could be normal, but there is a 20 to 30% chance it's not. So what do? we go to the next parameter. That is what we call, we take a quotient of the PSA to the volume of the prostate. Yeah, and we analyze it. I published paper on this a long time ago to say that if you have a slightly high PSA, normal MRI scan, check this quotient. If this quotient is high, you're likely to have prostate cancer. Now it's part of the mainstream 15 years later in the algorithm of prostate cancer. So what I'm saying is, I need to see that MRI report. I will analyze the PSA to the MRI. If the PSA density is high, it needs investigation. Don't believe the MRI, because we know that certain prostate cancer morphology evades MRI detection in 20 to 30%. We know that. Okay? So MRI scan is an important adjunct, but you cannot dismiss a high PSA density in the setting of a normal MRI. You can't do that. In fact, Caroline Moore in London just published, it's a small series of paper, but we're looking into it now more with interest. And Caroline Moore is in UCL. And what she did was to get 400 men in London to come for PSA and free MRI scan. Yeah? And the good thing about this small report, small, because, you know, in research, you have to have power. You know, so you can't accept it as verbatim. But if you look at that paper, the significant proportion of men are black. They came. So they had the PSA, had the MRI scan. Then, and then with all the ones with normal PSA were analyzed with MRI and biopsy. And significant proportion had aggressive cancer. So that study is called Reimaging study. And that's what I will quote for your relative. It needs to have a set. Don't take the word of MRI scan for it. And by the way, Nigerian radiologists are bad at looking at MRI scan. They are not very good at it. So they tell people, I've removed prostate aggressive cancer of men that were told MRI normal, and it's not normal. When we look at it, it's not normal. Okay, so don't believe that.
I wanted you to just, in simple terms, for the average man, because we know that men are such bad, I don't want to use the word patients, they're not as proactive as women when it comes to their health. So what would a woman like me tell my husband when I get home? Apart from the fact that he's always had his prostate checked and he's always based his confidence on his PSA level. So what would I say to him? You need to ask your doctor on a regular basis as a proactive check to make sure that you're in the clear, not just relying on your PSA level.
Yeah. A very important question. You see, women are oftentimes the best observers of men, because you know when a man wakes up in the night, he wakes you up, then you don't sleep. I know that Nigerian men like to have their own flat. Then the woman has their own separate. So you might be waking up 15 times. You might not. The woman might not know. But vast majority in UK, people share one bedroom. And so when you wake up, you wake the woman up, and she's noticing. I know a woman that told me that if the husband was saying everything was okay, she said, no. When you go to toilet, I listen through the door, and I don't hear the sound of the urine. That is very faint. You understand? That's a woman that is taking care. So that was how I was able to further dive down and be able to sort the man out. Yeah? So, a normal PSA is a good thing. I'm not dismissing it here. You have to put it in context and in conjunction with other parameters. If you have a normal PSA and you have symptom of urination that is changed, then you have to be looked at in more detail. You cannot rely solely on the normal PSA. That is what I'm trying to say. But if you have a normal PSA, no family history of prostate cancer, and you are not having any symptom, symptom of prostatic disease, by all means it's good. You check your PSA. It depends now. The next question, how often should you check your PSA? Yes, that has been looked at and confirmed. In fact, there's a study that was done in Scandinavia of thousands of men, and that confirmed what you should do. If you do your PSA at the age of 60 and it's less than 1, I can tell you 100% you're not going to have prostate cancer in your lifetime. But if you do your PSA and it's above 1, you will have to do other things. So, depends on your PSA level. A man who has a PSA of 3, let me take 3, because in Nigeria, the PSA is a general cutoff. That is no longer done. If you come to UK or US, Europe, everywhere, it's age-specific reference range. So a PSA of 3 is already too high for a gentleman who is 50 years old. Too high. But in Nigeria, a gentleman who is 50 years old that has a PSA of 3, it will be normal because their reference rate is less than 4, but that's not right. So you see all the things we have to think about when we see that normal PSA. That's to answer your question. Yeah? We have to sub-stratify and look at other parameters and other things.
Thank you. The truth of the matter is, this session is coming to a close, and it has been most informative for me, and hopefully all of you have learned something from this session that you will go with. But before we leave, what is the one message you want to leave us with?
Yes, so I listened to the financial talk and I thought, okay, my talk is going to come and depress everyone. I don't want you depressed. I just want you to know that all the problems that I've talked about now, there is solution, it's curable, it's a simple thing, and in the next few years, with all the research we're doing, prostate cancer will become like diabetes, and you can just live with it. Yeah? So don't be depressed. Just come solve the problem. You will be fine. Everything will be okay. Yeah? But please choose your surgeon. There is a good paper that I love that is titled How to Choose Your Surgeon. Yeah? Don't submit yourself. See, your body is special. You are a special human being. Don't go and submit yourself to be butchered and destroyed. And the repair is more expensive than you have to get it right first time. So I wish everybody all the best. I'm happy for you to pop into the Prostate Clinic when I'm around. Come and have a chat. As you can tell, I love talking about this. I've studied this thing to the doctorate level. I've taught so many people. I love to talk about this. I can talk about this all my life. And let me just talk to you and help you to talk to other people. I'm more than happy. It won't cost you any money. Just chat us and talk.
And I know we're about to wrap up this session, but I can't let you go without telling you his clinic is literally around the corner. He's right there. It's walking distance. We can get there in less than 5 minutes. So, guess what it's called?
You talked about branding. You have to say, it has to mean what it does. What it says in the thing. It's the Prostate Clinic, TPC.
And as you're driving down, you'll see the big P red sign. That's simple.
Yeah.
That's right there.
Of course, we treat a lot of discreet, very high profile people. There is no signboard. You just have a peace sign. Yeah, it's on purpose, just so that people can come in and without being stigmatized or anything like that.
Thank you very much, everyone, for joining us for this session. Thank you, Fanny, for being with us and all the others. We're going to take a short intermission, about 5 minutes, and then we're going straight into our final session. Please stay. You really want to hear about this one, the silent crises.